Thanks for all for joining. Sorry for those that were already logged in and heard us talking logistics, but thank you for joining today's talk. We're excited to have Jessica here. She's a neonatologist at Massachusetts General and the Brigham in Boston, and she's going to be chatting with us today about the use of electrical impedance tomography in the neonatal population. I'm Hayden Leeds. I'm one of the critical care fellows at Children's Hospital Los Angeles, and I am using EIT in our population as well in the pediatric ICU. And so we hope that throughout today's talk, we can discuss the use of EIT currently, both for research and clinical purposes in both the neonatal ICU as well as the pediatric ICU, and touch on some future directions and future research for the use of EIT. So with that, I'll let Jessica take over.
Great. Thank you so much for the invitation. I'm really excited to chat with you all about the potential of electrical impedance tomography to be the part of the future of having our respiratory care be a more personalized approach. So I just want to disclose that I serve as a consultant for Good Life Inventors to help modernize EIT designed specifically for neonates in the ICU. And I do receive EIT equipment for research from Centec and Temple. So for our learning objectives, we're going to go over electrical impedance tomography, the basic principles to make sure we understand how it works and so that we know how to understand the studies that are applying it. And then we'll evaluate current standards of neonatal respiratory care and reflect on the utility of using EIT in your practice. And then identify opportunities to improve neonatal respiratory management with EIT as a precision respiratory care approach. So, like I mentioned, we'll go over some basic principles. We'll discuss some reports of how EIT could be used to monitor for adverse events in neonates, how it can improve physiologic neonatal respiratory care, and be used for precision respiratory care. And then touch on some future directions of neonatal EIT reports of measuring pulmonary perfusion. So let's go over some basic principles. So currently, when we assess the lung, we try to look at the physical exam, the pulse oximetry, capnometry, ventilator mechanics to try to get an impression on the lung's function. And for lung imaging tools, currently you can order X-ray at the bedside. You could order CT, MRI, but CTs have the drawback of radiation, increased ionizing radiation, and both CT and MRI would require transportation in the hospital, which could be really challenging for critically ill neonates. Lung ultrasound is coming up and getting more popularized in the US, but that requires a technician to perform it, and it doesn't provide like a continuous report that is not operator dependent. So I want to talk about EIT, which can give some information about the lung imaging as well as comment on the lung function in different ways than the tools that we currently have. Let me get my pointer here. So EIT is a bedside tool, example like you see here, and it involves a belt of electrodes that's wrapped around the chest of the patient. So here's an example in the intubated preterm baby wearing it. And the way it works is we inject small imperceivable currents of electricity that is picked up by neighboring electrodes. And it takes advantage of the fact that tissue resistivity is different in muscle compared to fat, compared to air, which is usually in the lungs. And that's how it's able to generate this image of distribution of ventilation. So to orient you, think of it kind of like a CT scan where you have the ventral, dorsal aspects of the chest and right and left sides. And this is image is showing where air is entering in the chest, taking an average um, across the belt. And so for an adult, this is considered regional ventilation, but for our babies, we have the advantage of it taking up a lot of the of most of the chest. So it has a relatively closer representation of global ventilation in our population. In this cartoon, you can see an example of how this electrode is ejecting the electrical current around this alveolus at the end of inspiration, and then it's detected by this electrode, and it gives this measurement of impedance compared to at the end of expiration around that same alveolus, and it gives this nadir. So this delta, this difference of impedance has very close agreement with tidal volume. And this nadir would represent the end expiratory lung impedance, which is surrogate for end expiratory lung volume, which we could use to comment on functional residual capacity. Here's an example of what it would look like at the bedside. You can see the air distribution in the chest, anterior, posterior, right and left halves of the chest, and you get breath by breath feedback. In this system, it's picking up 50 images per second, and you have this global plethysmogram that incorporates these breaths, that delta we were talking about, and if the patient is intubated, you can also include a flow sensor to also measure ventilator parameters like your tidal volume, your lung compliance, and but the patient doesn't actually have to be mechanically ventilated. This could be done in patients who are on the oscillator, who are on non-invasive ventilation, or even just on room air. But you wouldn't have necessarily have all these other measurements, but it's really a very, it can be applied in a variety of situations. And here's an example of in an adult looking at normal bilateral ventilation on CT imaging and what it would look like on EIT versus if there was a pleural effusion, lower right quadrant, it would look like this on EIT to show where aeration is entering in the chest. And if there was a one lung ventilation, like here in the left main stem bronchus, it would look like this on EIT. How it would potentially comment on function. For example, on the CT scan of this adult who has very diseased right lung here, you get all the architecture, which, but you don't know what areas potentially are participating in gas exchange. And EIT can help show where those areas are. And then this is what the patient looked like after the transplantation. So with EIT, it has the benefits of being non-invasive. There's no ionizing radiation involved. It's a bedside tool, gives continuous real-time images, operator independent, and we'll discuss how it has the potential for providing precision respiratory care. Temple had FDA approval in December 2019 for patients who have chest circumference of 37.5 centimeters and above. So that's roughly the size of a former term 1-month-old baby, so through pediatrics into adulthood. And then Centec recently got FDA approval this month for preterm babies, including preterm babies, so chest circumferences greater than 16.5 centimeters. Contraindications for using EIT include if there's any medical device use like that uses electricity like a pacemaker, or if you're just not able to have that skin electro contact. For example, you have skin conditions or chest tube, extensive chest tube dressing that would affect the readings. But like with any clinical tool, you have to have the context to be able to interpret it, because these changes in regional ventilation that EIT is able to measure, it's very nonspecific. One, it's not anatomic. We comment on right and left halves of the chest, but there was a situation where there's a mediastinal shift, in an unrepaired congenital diaphragmatic hernia, or if there was, a tension pneumothorax. Like, it's not going to comment on right and left lung. It's just looking at right and left halves of the chest. And then, as you see, it takes like an average and of these quadrants. So it's not going to be specific in the right upper lung, or for example, of like where there could be an area of atelectasis. So you'll have to take that into consideration. Um, if you want to measure overdistension or collapse, if it's a larger patient, you're not going to be able to measure that outside of the region of EIT. So that's where it's a regional for older patients compared to younger preterm babies. And EIT quantifies the relative change in impedance in one patient. So you can't compare the absolute values between patients because everybody has a different body mass, different amounts of edema, but this is really great for trends in the same patient. And a lot of the features that are currently being reported in the literature have to use the offline analysis tool that you're not able to use right at the bedside just yet. And then in terms of the neonatal belt, the duration of how long you could wear the belt, it varies between companies. So some could be as long as 24 hours and some as long as 72 hours. And it's very safe and feasible to use in neonates. In this largest study, the CRADLE trial done in 4 European university hospitals, they used EIT for 72 hours at the time, and they reported that they only need to use one belt adjustment or reapplication of, in this version, it's a fabric lined belt, so that uses ultrasound gel as their contact once a day, and they did not have any moderate or severe adverse effects. And then some babies, because of the prematurity and sensitivity to skin, that there is some like transient redness, similar to the pulse oximetry or other leads that we clinically use, that we may see that there's some transient redness. So by changing the position, taking a break, then it resolves. Next, let's get into different applications of EIT. So what's for monitoring for adverse events. So one of the things that is a real struggle at the bedside for neonatology for intubated patients is having the perfect endotracheal tube positioning, because for those of you who work in the unit, you know that that if a baby has an extension of the neck, it could be close to being intubated, versus if you have a lot of flexion, you can end up with a right main stem intubation. And so it's hard to find it just right, because we tend not to use cuffed endotracheal tubes. And babies are can be active, moved in different positions, skin to skin or proning. So, how we go about is just by looking at the pulse oximetry, saturations, try to auscultate and get X-rays. But, what if you could use electrical impedance tomography, a continuous, a non-invasive, no radiation-free tool to identify when there's malposition of your endotracheal tube. So in this example, just to like show the concept of in 18 children who were intubated for cardiac catheterization, they showed that as an example of what the aeration looked like with spontaneous breathing versus when they had mask ventilation versus when they had an endotracheal intubation, one lung ventilation, or when you had the ideal positioning. And so that could be a great way to troubleshoot. And I know my nursing and respiratory therapist colleagues, that like really feel that frustration every time you have to retape your endotracheal tube, get an X-ray, find out it's too deep, and you retape, and it's like, oh, now it's too shallow. But if you could have this feedback at the bedside, I could see a lot of potential of causing less stress on the infant with all the extra stimulation trying to perfect your endotracheal tube positioning. This is a case report where it shows that EIT could detect pneumothorax. This is an example in a 29-weeker who you could see here had received surfactant endotracheally. But this graph shows the distribution of ventilation. The orange is right lung, the blue is left lung. And this bottom graph shows an expiratory lung impedance, which is a surrogate for your functional residual capacity. And so there's concern here retrospectively that when they gave the surfactant, that it may have been unequal distribution because you had more aeration on the right side compared to the left. And then at 36 hours of life, the baby was having desaturations. They gave more surfactant. It seemed to get better transiently, but then was still having desaturations. They got an X-ray and they saw that, oh, there's actually a tension pneumothorax here. But that's important to pay attention because on EIT, air on the right side of the chest is not going to be distinguishing whether it's in the lung or it's outside the lung. And so here you can see that even though it looked like there was a good amount of air on the right side, but if you look at the FRC, the inexpiratory lung impedance, it actually dropped on the left side, supporting that there was this tension pneumothorax that caused this left-sided atelectasis from the mass effect. And that's how you would interpret this. And then they needle decompress, and then there was another recurrence of the pneumothorax again. And this is another representation of how that looked on EIT. The next section I want to get into is what are the opportunities of EIT in precision respiratory care? The literature is still limited in our neonatal population, so we'll learn from the adults and other populations because the literature is more expansive compared to ours, but it's coming, it's getting there. This is an example on how in this adult patient with pulmonary thromboembolism and pneumonia on the left lung, like you see here, was scheduled to have a BAL, bronchial alveolar lavage. And the concern was the patient was so labile, they didn't want to do this invasive procedure multiple times, go in, wash out, remove the bronchoscopy, get the X-ray, find out you have to go back in again. And so they used EIT to give that real-time feedback on how the aeration was improving with their intervention. So you can see how there's less aeration on the left side. And then during the bronchoscopy, they were able to improve and gain aeration. They could see that in real time before ending the procedure. So this is an opportunity to, take a patient case by case instead of following a generalized protocol to really target what this specific patient needs with this level of lung disease at this time to tailor your therapy. I also want to share our work that was recently published this month of how we used EIT to identify optimal positive and expiratory pressure in severe bronchopulmonary dysplasia. So that's chronic lung disease of the premature infant. And so for those of you who work with this population, you know that it can be a real struggle because infants with bronchopulmonary dysplasia have a heterogeneous lung disease, meaning like, for example, in this X-ray of this patient, that when you have different areas of atelectasis and from perhaps like stiffer lungs and stiffer lungs who have areas of over distension, that you're really trying to balance how to optimally oxygenate and ventilate them, because by trying to increase the pressure to try to resolve areas of atelectasis, you may end up causing more barotrauma, volume trauma on healthier lungs that have better compliance and are overdistended, and so it's a real struggle to identify what is that optimal PEEP. And so we end up doing a trial and error approach of just trying different settings, maybe come back, get a gas, get an X-ray, watch the exam, and then realize, oh, that didn't work, and maybe go back up. And depending on how labile the infant is, they may not be able to tolerate larger changes, so you end up making very small moves and have a long ventilator day course. And so, looking at the adult literature, they have a method that they've reported called PEEP titration using EIT guidance. So what that involves, if you look at this graph here, for example, so the x-axis shows the different PEEP levels. This black square with the dashed line represents hyperdistension. This triangle with the dashed line represents areas percentage of collapse, and then this gray line represents their lung compliance. And so what's done is the patient is have a lung recruitment maneuver, so a high level of PEEP and put on high level PEEP, and then gradually walk down on PEEP levels. And you'll see as you go down on PEEP levels, as expected, the amount of atelectasis, collapse increases, and the amount of hyperdistension goes down. And so some report what's the optimal PEEP is where it lines up with the peak of the compliance. So, so some people report in this example that this patient's optimal PEEP is 14, but others look at the intersection of this graph to say, I'm looking for the PEEP that balances minimal atelectasis, minimal hyperdistension as a sweet spot. And that's what we looked at for our neonatal, our infant population with BPD. And so in this case series, we want to look at the feasibility of doing an adapted PEEP titration in BPD. So here you can also see examples on EIT of how the baby is breathing, can appreciate this how the breaths are not just even inhalation, exhalation. He's really working hard to exhale and empty because you can see here on X-ray that he's very overdistended and concerned for air trapping. So I'll go over two cases where we to demonstrate this point. So on how our experience was. So for this first patient, he was on a PEEP level of 14. And there was clinical concern that he was overdistended. This was after receiving a tracheostomy, so the team want to know what is his new baseline now that he has a cuffed endotracheal tube with the tracheostomy. That what should be his new baseline setting for his optimal PEEP. And so we gradually walked it down to a PEEP of 6. Here you can see the mean airway pressure and tidal volume, mLs per kilo, that correlated with these different PEEP levels. And then on EIT, we also saw at what point the baby started to show evidence of lung collapse. And so that's represented here in this dark blue. And we start to see it in this patient at a PEEP of 8. And then here we also looked at the distribution of ventilation. So if you divide it into quadrants, that's what these percentages represent. It actually didn't change too much as you went down on PEEP. So with this data, we wanted to avoid atelectasis. So the lowest PEEP level before that occurred was 10. And the patient actually stayed on that PEEP of 10 for another 10 months after. So it shows that there was a long-lasting, you know, long, like effects of having of choosing this lower setting, and there wasn't a late onset atelectasis, for example, that you had to go back up to the previous baseline of 14 that the baby ended up being adequately ventilated and oxygenated on a lower PEEP of 10. And the FiO2 had improved from the oxygenation improved from the baseline of is around like 45-50% to when put on the lower PEEP of 10, it was like 30, around 30-35%, I believe. So so clinically that matched to that he liked that setting. Here's another patient who similarly was overdistended on X-ray, was very labile, was on inhaled nitric oxide, muscle relaxation, like sedated, like the whole book was thrown at him, and he was like escalated, like for an acute hypoxic event. It's like very an elevated PEEP settings to go up to 12 from his baseline of 10. And he was very labile. His FiO2 was like 90, 100%. And so the team was like very hesitant about, making ventilator changes and the PEEP because they recalled the recent recall of how labile this patient was. And didn't want to make any big changes. But that's where EIT was really helpful in this case because it was very powerful to see the images and to see, like, as you change it in real time, whether you were improving gains in areas of gains in ventilation, or if you were causing atelectasis, how you and so to help give confidence in the team that the baby lungs were showing, or these measurements that they were tolerating it. And so we gradually walked down from a PEEP of 12 to 8. He had similar distribution of ventilation, but we actually saw, and while keeping the same delta P, and we saw that the tidal volume improved. So you actually see there's areas of gained ventilation by coming down PEEP because we were resolving the air trapping in those areas. And this is an example of a case series of controls with intubated children infants without lung disease, just to show this what it would look like by dropping the PEEP by roughly the same amount, by like 4 centimeters of water, but like how much more compliant infants' lungs should be. And you would see loss in ventilation, like here represent red, but you can see how diseased our BPD patient's lungs were. In that same patient, we also showed that when going from PEEP of 12 to 10 to 8, that we resolved the overdistension without inducing atelectasis, like you see here, and the compliance improved compared to that control, like you saw in the previous slide, like how that there was collapse induced by dropping the PEEP down to 3. And so in that bronchopulmonary dysplasia patient, this is what the X-ray looked like afterwards. There were still areas of atelectasis, but this is measuring relative. So there was no increased collapse, increased atelectasis compared to before. And you can see much less overexpanded. And this baby stayed on this lower level of PEEP of 8 for 2 months after this assessment. So, which, at the bedside, we typically wouldn't make such a big jump of going from 12 to 8 in this chronically intubated labile baby, but this images were empowering to help make this informed decision instead of just trying to maybe go by once or twice a week, trying to using our current tools. So. And then in summary, out of our 5 EIT assessments, 4 of them were successful with this PEEP titration in the BPD population. And out of those 4 cases, 3 of them ended on identifying a lower PEEP than the team clinically chose for the patient, and they were able to stay on that PEEP for over 2 weeks, which is what we considered unsuccessful. And then 1 of those 4 confirmed that the PEEP that the team clinically chose was already optimal. For the patient who failed the PEEP titration and went back to baseline after 1 hour, this was we attributed to how dynamic the respiratory lung physiology is. Because at the time we were doing the assessment, it was between feeds. And so it was kind of like ideal, kind of more fasting situation. But then once the feed occurred after the IT assessment, the babies had distended belly and had abdominal competition that led to a different respiratory physiology than at the time that we assessed. So that's why we think the baby needed that higher PEEP during the times of feeds. And so from this experience, we learned that we want to keep the EIT on for at least a shift, ideally like the full 24 hours, just to make sure that we observe in different conditions, because they're so dynamic, that if there's signs of decrease in the FRC, decrease in expiratory lung impedance, or changes in the distribution of ventilation, that we can adjust it in real time instead of just using a one snapshot in time, just to be able to have that trend. And then, let's see. And then this other case that I want to report that was published this year was how this group used EIT in preterm babies on high frequency oscillator ventilation. So, this is also another area for us where it's kind of a black box. You're transitioning from conventional mechanical ventilation to the oscillator. There's this arbitrary go up on the mean airway pressure by 2, just because that's just practice and it's not necessarily specific to that patient, to that patient's lung disease, and what percentage of their lung is still recruitable. And in this paper, they talked about their practice of how they adjust their mean airway pressure based on oxygenation and try to do these lung recruitment maneuvers. But when they compared to a group who was using EIT to help guide, how much of the lungs was still available for recruitment, they saw that they had improved transcutaneous PCO2 when in this group with the EIT guidance, compared to the ones who were arbitrarily just trialing and changing the mean airway pressure. And then for those who were not using the EIT guidance, EIT was able to measure that those non-recruitable maneuvers didn't improve their ventilation, and they also show that with the EIT guidance that there was relative less overdistension as the final setting compared to the ones who were using just usual standard of care of not having this data. Great. And I think we have some time to touch in on this like really exciting future directions of where neonatal EIT is going on, not only measuring respiratory, ventilatory distribution and help guide ventilator management, but to also look at pulmonary perfusion and understand ventilation perfusion mismatch as etiologies and understand the etiologies for why our patients have hypoxemia, which can sometimes be a mixed picture. So to just be able to have that guidance. Look, the adults, explored this first. Their method is that they've established is to use this conductivity contrast bolus method. And what that means is that they only perform this on intubated patients who they're able to medically or are on the ventilator cause a breath hold, so that you don't get interference with the changes of impedance during a respiratory cycle. And then they inject the hypertonic saline bolus so that it really lights up with that osmolality change that you can see the change in impedance on where the distribution in the lung for pulmonary perfusion. And then they restart the mechanical breaths. And so this practice has been introduced in case reports for pediatric patients. One done by our group, where this was in a 4-year-old who we wanted to evaluate regional ventilation perfusion mismatch, and we did a similar apnea maneuver with the hypertonic saline bolus, and you can see this is what the map looked like on EIT for ventilation, with the percentages representing the quadrants of distribution ventilation. And this is what it looked like with the perfusion, with the saline bolus highlighting the areas of perfusion. And then with the, and when you overlap the ventilation and perfusion map, that's how we generate this EIT perfusion ventilation map to show areas on where there is mismatch. And here green is represented, it's well matched, versus blue, which is dead space, mostly ventilation, versus red, where there's mostly perfusion, like from intrapulmonary shunting. And another thing we're exploring is it's sometimes patients are not able to, or pediatric patients or infants are not able to tolerate a hypertonic saline bolus. So we performed this other methodology called pulsatility, where we look at the change of impedance synced at the time with heartbeats, and to see without giving an injection, to see if at the change of RV ventricular contractility, if that's the surrogate of what the change in impedance at that time represents pulmonary perfusion at that moment. Similarly, take those maps, overlap each other, and we have a kind of similar picture where there was 50% of the perfusion reported on the right-hand side for the saline bolus method, hypertonic saline bolus method, versus 42 on the right with the pulsatility method, but without needing to provide an injection. So this is something that we're exploring. And then this last case I want to go over that was recently reported is, you think about who else would benefit in our neonatal population to really understand their pulmonary perfusion. Well, it's our patients with congenital heart disease. And so here, so depending on the physiology, of course. So here's an example of a patient who had tetralogy of Fallot that was repaired, and also had bilateral pulmonary branch stenosis. So this baby had a BT shunt for this at around 10 days of life. And at the time of this assessment, now he's 7 months old and had his full repair. But post-operatively, they saw that he had severe hypoxemia. He was not responsive to INO, and there's concern like, is this related to inadequate pulmonary perfusion from this stenosis of the pulmonary arteries, and if it was not adequately um, uh, patent. And so the tools that we typically have at typically have at the bedside includes an echocardiogram. It did show some decreased like right side ventricular dysfunction, but it did comment that there was right-sided pulmonary artery stenosis and severely angulated left PA pulmonary artery. And they performed a chest CT, which also confirmed that here's the chest CT, which also showed that same anatomy. So then they went forward with the angiography and the cardiac cath lab, and they injected the contrast in the right pulmonary artery, and saw that there was distal hypoplasia compared to the left side, where there was just like very severely stenotic pulmonary artery, not that they deemed was unsuitable for repair. But do you go in now that you see this? Do you go in to try to revise this? Well, they used EIT, and they looked at the ventilation, the perfusion. They did use the hypertonic saline apnea breath hold like contrast protocol. And then here you can see the perfusion, and then here you can see their VQ map where they overlap the ventilation and perfusion. And you can see that actually there was adequate right lung perfusion, certainly not on the left lung like we saw here in the cath lab, but because functionally, even though there was distal stenosis, the blood is still making it to have adequate VQ matching. So the team chose not to intervene on that right PA, and the patient eventually was able to be stabilized and extubated and tolerate lower the lower acceptable range for SATs. So that's very exciting to be able to, like we mentioned, how EIT is able to comment on function as well as provide imaging. And so take home points. EIT is a non-invasive, radiation-free, bedside, real-time lung imaging tool with a growing interest in pediatric applications, and has the potential to enhance neonatal respiratory care and precision medicine. And I want to thank my funding sources, thank my multidisciplinary team. We call ourselves Encore, Enhancing NICU Considerations of Respiratory Settings with EIT. And we're consists of neonatologists, respiratory therapists, NICU nurses, engineers, and my email's here if you have any questions or want to reach out for collaboration. Thank you.
Thank you so much, Jessica. That was a great presentation, and I think really highlighted the utility of EIT, especially as this bedside tool, where I think you really focused on trends over time, and for specific patients where each patient is their own control, how can we monitor them without having to take them to a CT scanner or see the physiology in real time. I know in our own unit, that's been the most helpful utility of EIT, is seeing that physiology played out at the bedside while we can make adjustments and see the effect, whether it be PEEP titration or now the new added advantages of this pulsatility and perfusion studies. I think too, this just highlights finding that kind of optimal balance. And I think in many of the cases you showed figuring out where like optimal FRC is, whether that be for perfusion, ventilation, or both. It can be really helpful. I think oftentimes we are flying blind, so to speak. And so this is a nice way to really guide management. And I think that's an area of active research for us here in the pediatric ICU, is finding who has recruitable lung disease and who doesn't, who may benefit from higher PEEP strategies and who may be not necessarily harmed, but may not benefit from those higher PEEP strategies, in which case maybe the perfusion and ventilation is improved when we go down on PEEP. It looks like we have several questions in the chat, so we can open it up for discussion. So it looks like the first question that came in is, when you were presenting the series of patients that you were doing the BiPAP to CPAP weaning. Was the position of the patient constant between BiPAP and CPAP, or were there changes in positions?
Yes, yes, it was constant supine. Yeah. Because certainly that can changing positions would change the gravity dependent um, uh, uh, recruitable lung areas. So yeah, yep, great question.
Yeah, definitely. I think some of the work done out of Dr. Amato's group has showed that you can do tilt tests and show that the ventilation and perfusion will alter as you would change the position of the patient. Another question came in about the benefits of using this in patients that are on the oscillator. I think this is, you showed some of the work being done in this area, and this is an area that I'm personally really excited about, and I think working with the various companies to create an oscillator feature. Currently, it's more qualitative in nature, but again, this is, I think, is where having these patients on the oscillator under continuous monitoring, we can start to see overdistension over time, whereas previously you had to go off of the wiggle or look at the patient and get kind of a crude measurement or look at the chest x-ray. And so hopefully with time, we'll be able to use this tool more consistently on our patients on the oscillator. Have you had experience in your own unit using the oscillator and the EAT?
Yeah, so we use the oscillator for rescue modes of ventilation. So I've not personally done it yet on our population, but the Temple device, for example, has like a specific modality to look at oscillated breaths. Yep.
Yeah,
So.
that's like I mentioned, that's still under research and development, and I think it will
Mhm.
be something that will hopefully be available to most clinicians at the bedside, at least in pediatrics. My hope is that at some point we'll be able to like titrate mean airway pressure, similar to what we do with
Mhm.
PEEP, and start to see that balance of overdistension and collapse with trend reports, etc. So stay tuned for that.
Mhm.
Um, the next question is about your PEEP titrations and whether you use muscle relaxation or if these
Mhm.
patients are spontaneously breathing.
Yeah, great question. So some patients were muscle relaxed and others were spontaneously breathing. Yeah.
And then,
So for our controls, all of those patients were about to have non-pulmonary related surgery, like for example, removing like a polydactyly finger or things like that. And so they were all sedated and muscle relaxed. But for the BPD population, yeah, out of the 5 assessments, like some were muscle relaxed and some weren't. So the one that failed, that one was spontaneously breathing. Yeah.
perfect. Yeah, I think and this actually gets to the next question. So to use the actual PEEP titration tool on the device, it works or really only works if the patient is muscle relaxed or not spontaneously breathing, as it needs stable breath cycles to calculate the compliance at each pixel and get that nice compliance and over distension and collapse curve where it looks at the crossing point. Obviously, you could do this offline and do your own analysis with the spontaneously breathing patient. But for the actual tool to work, often works best if they're completely either paralyzed or not spontaneously breathing. And then the next question mentioned that in the spontaneously breathing patient, where maybe it's more difficult to get the measurements of collapse and over distension, are there other parameters that we could use, either EIT or other, to guide PEEP management?
Yeah. So I think on the first point, I think that's like a fantastic point, which is why we needed to adapt the adult strategies to our neonatal population because as a whole, we really try to avoid muscle relaxation in our babies and promote spontaneously breathing because having that diaphragmatic health and they're able to recruit their lungs better spontaneously than us when we have them paralyzed. And so we didn't use the automated like PEEP titration tool from the adults. Like we were manually changing the PEEP after observing like around like 20 minutes at a time just to watch for tolerance, just because like our population with their chronic lung disease um, and their heterogeneous like amounts of compliance, like we want to look for signs of relatively like later atelectasis. And that's why we had a slower PEEP titration compared to adults who could like do it in minutes. And so the second point, yeah, so certainly when they're paralyzed, it's much easier to read the EIT compared to the spontaneously breathing because each breath is so dynamic. So we really try to get like a representative point in time. It takes a lot, like our team, to really calm the baby down, try to like give the pacifier, let them relax, try to sleep, and truly try to look like and try to use those regions as more representative to try to minimize the artifacts and to help with interpretation for each step. That's such a great point. Yeah, and otherwise, other things we could use other than EIT to help with optimal PEEP, like, you could look at the loops on the ventilator, but it could be challenging if the patient does not have a cuff tube and has a considerable amount of air leak. But the ventilator could comment on where PEEP compliance is. So you could judge based on that. And but yeah, but I think this is where like having the images from EIT at bedside like could really just really make the picture clearer of what's going on with on each setting. So compared to what we currently have. Those are
Perfect.
great points.
Yeah, thank you for whoever submitted that question. Again, this is an area of my own research. Is trying to compare EIT PEEP titrations with other lung mechanics and see if they're comparable or in which patients may they differ, such as PEEP best compliance or improved oxygenation. And I think if there's others that are doing the same work, I think it's really important. Because again, not every patient or not every person is going to have EAT, and not every patient is going to tolerate true PEEP titration. And so how can we look at other parameters? The next question is about Pendelift and whether you have had any cases of this and whether you can identify that with the EIT. This is, again, another exciting point with being able to see real-time physiology at play at the bedside.
Yeah. So we looked for Pendulum in our population, our BPD population, but we didn't see it. We only had 5 assessments. So it could be that different, BPD is such like a wastebasket kind of diagnosis, meaning it's not very specific to the lung pathology. There's so many different phenotypes and different etiologies for what we call BPD. So I think that would be really interesting to, have a larger study, multi-center to really look at all different populations of what we call BPD to try to see if EIT can help distinguish like the different phenotypes and help guide management that way, and certainly pay attention to Pendulum if that's contributing to lung disease. But yeah, that's a great question.
Great. Yeah, I think EAT is great for identifying it in the subset of patients, and then how do we manage it is the next question, and obviously deserves more studies.
Yeah,
Somebody
because
asked
there's no
about,
other tool that's measuring Pendulum that we have at the bedside for these babies. Like this will be the only way to know. So yeah, I think that's a great point.
I think it's been fascinating with a few patients we've had on the oscillator. You can actually see the pendulum in action, and I know that's been described as a potential mechanism for CO2 clearance in these patients, and you can actually see it in real time with the EIT, which is really cool. The next person asked about, when doing PEEP titration, do you always do a recruit maneuver before the decremental PEEP titration? And I think that's a great question, and something that I have taught other people. We personally always do recruitment before for the effective like tidal recruitment. I'm curious what you would do in your patients.
Yeah, no, that's a great point because that's how it's also reported in the adult literature, because you want to make sure that you have really represent like what's the that all the areas are recruited before you walk it down, because the areas of measured relative atelectasis compared to over compliance is going to be based on that first value. Specifically for this cohort, though, we saw that on X-ray that these patients were already very over distended. So we personally didn't, we adapted our protocol to, in this case, to not increase the PEEP even further and risking air leak in those poorly compliant lungs. But yeah, and we were able to still make assessments with that adaptation. So yeah.
And then somebody asked about the tool being only FDA approved for neonates greater than 30 days. So how are you getting parental consent for is this all for research purposes for those that are under 30 days?
So so actually now there is the Centec has now FDA approval for patients with preterm patients with chest circumferences of 16 and a half. So you don't need to be 30 days old for that. So that's going to be really up and coming with having that more accessible for hospitals to have in their units to look at the smaller babies. And then but specifically for these cases, so the BPD population, they were all like corrected um, 30, they were all corrected, sorry, like 43 to like 48 weeks gestational age. So they used the pediatric size belt that was FDA approved. But for our smaller babies, like the RDS study looking at the CPAP modalities, yes, those we obtained parental consent for research.
Yeah, I think hopefully as time goes on, we'll have more FDA approval for some of these features. So for example, I think the VQ tool is not FDA approved yet in pediatrics for clinical uses and is for just research at this point. But I think with all of more research, case studies, et cetera, coming out showing that it is safe. I know other groups are trying to find that right concentration and right dose of sodium chloride or sodium bicarbonate in the pediatrics. And I think right now it seems like half per kilo of 5% sodium chloride seems to be a safe level for most patients and doesn't affect the serum sodiums in these patients.
Yeah.
Obviously, it requires somebody with a central line to do, but hopefully, again, with time, things will be more FDA approved.
Yeah, and then, we also use it in our hospital for specific clinical consultations as well. So that involves a conversation with the family before doing the assessment. But there's actually in the NICU like lots of things that is not FDA approved for our population that we still, have a conversation with the family about risk benefits and applying at the bedside. So some of those clinical cases, it's really just like a case by case. Yeah.
Perfect. And then it looks like we're pretty much over time, but with our
Mhm.
last question here, somebody was just wondering about recruitment maneuvers and using EIT in the post cardiac surgery patient. I know you presented that case with the patient with tetralogy of Fallot and the bilateral pulmonary artery stenosis, but do you have any other experience? They specifically were mentioning in like a single ventricle or Fontan patient.
Oh, sorry. What was that last part
Oh,
specifically?
they were specifically mentioning recruitment or in postoperative patients following Fontan or single ventricle palliation.
Mm. I don't personally have experience with that, but I am working on collaborations with Boston Children's in their cardiac population. So hopefully we can have a follow-up webinar and let you know how that goes. So with our experience in the cardiac population, I think that'll be really, really like groundbreaking for them. Yeah.
Yeah, I agree. I think hopefully it looks like we have a couple people that I recognize from the CTICU world on the call. And so hopefully with more collaborators in the cardiac ICU, we can get people on board to use this. I know we currently, again, similar to you, we provide kind of consultative services in our CTICU where we'll use the tool. And we're a little bit limited immediately post-operatively with open chest, et cetera. But I think this is an exciting world. And there's a lot of case studies out there in the post-surgical patients as well. So stay tuned for more in that area. Well, thank you, everyone, for your attendance and for this great discussion. I personally learned a lot today and hope you did too, and look forward to continuing these discussions moving forward.
All right, thank you so much, Hayden. Thank you, Temple. This is fantastic. Thank you, everyone.